Save. All right. So, respiratory. Okay. Um, so primary purpose of respiratory system is exchanging oxygen and carbon dioxide, but that's not the only thing it does. All right. We'll see um, pH control. Patients will, well, not patients, everyone breathes out hydrogen ion, for example, in their breath. So when you see like a diabetic ketoacidosis patient, a DKA patient, they coming in there, that's part of the reason. They're trying to get rid of excess hydrogen because those ketone bodies that are in their bloodstream are acidic. Um, Defense against pathogens, we have the mucociliary escalator, so we're secreting mucus and then we catch stuff in it and then we move it up, swallow it, goes to our stomach, we get rid of it. Movement of sound against the vocal cords, that's how we communicate. Okay. And then we need moisture and olfactory receptors to smell. So that's why when you're sick and your nasal airway is dry, your sense of smell goes away. They say something like 80% of your taste bud function is actually due to sense of smell. So that's why you kind of lose your appetite. You can't smell the food, everything's bland. And I don't know about y'all, but I do dumb things like go for extra spicy food when I'm sick. Like you want to taste something, right? Wise decisions. All right. Upper respiratory versus lower respiratory. So upper respiratory, we have our nose, nasal cavity, the paranasal sinuses, and then pharynx, and that's where we draw the line. We see bacteria in these areas. That's normal. Once we go down here, we really shouldn't see bacteria. Yeah, there might be some transient bacteria, but we get rid of it. We move it up the trachea and we swallow it. So lower respiratory, larynx, trachea, the bronchi, bronchioles, alveoli. Alveoli. Alveoli is where gas exchange happens. So when we start talking about where does respiration happen at the lung level, alveoli. That is it. The rest is like dead space. You're just moving air through it. It is just a pathway to move the air in and out of the body. But at the alveoli, they are simple squamous cells, and on the other side of them are capillaries, also lined by simple squamous cells. That's where we do gas exchange. So, external nares, that's your nostrils. Air moves into nasal cavity, pseudostratified, goblet cells to catch things. Nasal conchae, you have superior, middle, inferior. Primary purpose, warm the air, moisten it before you breathe it in. If you've ever gone out in extreme cold and dry air, it kind of burns. If you work out in there, in that environment, it kind of burns your chest a little bit. And that's because you can't warm it up quick enough, moisten it. And so it kind of irritates you. Nasal septum, so that's dividing the left and right cavities. This is the one like you hear about people get deviated septums. They can't breathe through one nostril. Usually when they break their nose, that's a common causation. And then they can surgically correct it. They got to re-break it, readjust it, and put it. Okay. Pharynx, we looked at nasal, oral, laryngeal already. So I'll just go over that again. Okay, so I guess we'll mention it here again because we need to be clear on a couple things. Nasopharynx, pseudostratified, air only. Oropharynx, stratified. Why stratified? Because food is going to pass over it and it's going to like remove some of the layers as it goes through, abrade it. So food and air. Laryngeo, food and air again, so stratified. What we will see here, we're going to see a division. We're going to divide into two tubes. We're going to have our trachea and we're going to have our esophagus. We do not want food going down trachea. That is a big no-no. So we have a structure called the epiglottis. The epiglottis is like a little doorway that when you're swallowing food or drink, it closes so things can't go into your lungs. Because if things go into your lungs, you are aspirating them. That means bacteria is going to get down there. You're going to get pneumonia. So what happens? We have cough reflex. When something gets into there, you swallow water wrong and you start coughing violently, that's to get it out. That's to push it out. You'll see in people that are like quadriplegics, alcoholics, they lose that and they tend to end up with pneumonias frequently. And that's because they don't have that reflex anymore. All right, so there's your naso, oro, laryngeo. That's epiglottis right there. That's the structure that'll close off the trachea. The sinuses, you guys go through this, go through it in lab, look at the models, okay? Purpose, lighten the head, and also to help with sound production. That's why when you're sick and your sinuses are all clogged up, you sound kind of funky. That's the reason. The 9 cartilages of the larynx. So we have epiglottis, that's the close off the trachea. Cricoid, so he is an entire ring and keeps the airway open. He does not close. Thyroid, that's where the vocal cord is attached. So thyroid cartilage is like Adam's apple. So on males, it responds to testosterone and grows longer. As the vocal cords get longer, because they're attached on the rear to the arytenoid cartilage, as they go longer, it's kind of like a looser guitar string, if you will, on any string instrument. Longer and looser, deeper voice, okay, deeper tone. And you can see, like, when I touch it, my voice starts to change. I'm not changing my voice. I'm just moving my thyroid cartilage. Everyone at home doing it now. All right. Arytenoid on the back side, and corniculate. So arytenoid, corniculate. They look like a bird with a beak when you look at the model. So I always remember Artie the bird eats corn with his beak. That's how I remember who's who. Okay. And then cuneiform cartilages. So we want air only to enter trachea. So the epiglottis will close whenever we swallow, really whenever we swallow, okay? But we're mainly, here we always say when we swallow food or drink, but it's whenever we swallow in reality. There are 2 sets of vocal cords. There's what's called the true and the false vocal cords. The true are the ones that allow us to vocalize. That's what's making sound. So they are attached to thyroid cartilage and arytenoid. And we change like pitch, we change noise by loosening and tightening them up. So on the arytenoid, we have muscles attaching there. And as we tighten them up, pitch will increase. As we loosen them, pitch or tone will decrease. Okay. Glottis is just the opening. So when you're looking at the model and you see the hole going into trachea, that's glottis. So that's just that space. All right. So false vocal cords, not for making sound. We think they are vestibular. They're kind of ancient folds. They do still work for us. They work with the epiglottis to block the glottis opening. So when we swallow food or drink, and then they allow us to increase abdominal pressure. So that's where we do like Valsalva maneuver, where you bear down, you take a breath and you bear down and create this pressure internally. So they do play a role in that. So like when, women are delivering a baby or someone's constipated, you shouldn't push then. Okay, that's how you end up with hemorrhoids. It can also be a maneuver to correct like SVT that we had talked about with the heart. That Valsalva maneuver can do that. It can actually help slow the heart rate. So it has purposes. All right. So when we look at the trachea, it has to stay open. And you guys looked at these in AMP1 here. You looked at this tissue for the pseudostratified epithelium. That was the slide you looked at. And when you looked at hyaline cartilage, that's the slide you looked at. Okay? You just looked at the pieces. Now we're going to look at the entire structure. So we must have cartilage here to keep it open. The airway does not collapse down, all right? The esophagus collapses down. Everything in the GI tract collapses down unless food's passing through it. We don't want to keep that wide open. We don't need to. But airway stays wide open. Now, as the trachea descends and we hit the Y to split to the lungs, that's carina. That's what we're talking about. And we start what are called the primary bronchi. Every time they split after that, we change the name, okay? So we go to secondary, tertiary, whenever they split. But primary bronchi, you only have two, one going into each lung. The right side is straighter. So what happens when, like, typically when kids inhale things, like a Lego or something, whatever they inhale, okay, and it gets in there, it usually goes to the right side because it's straighter, and so it just lodges in there, and we go and extract it, right? You tend to end up with right-sided aspirated pneumonia more often than left side for the same reason. They inhale the bug, it gets down in there. That's where it tends to end up being when you talk about like lobar pneumonia, where it's affecting one lobe. All right. So the epithelium, like we mentioned, pseudostratified. We have cilia. We have mucus. So things we breathe in get stuck in it, and then we move it up. If you're a smoker, you destroy that cilia. So what happens? Stuff just start coming down. So you end up with pneumonias more often. So the smoking destroys that. You don't repair it. You paralyze it, and then eventually you destroy it. So that's why a lot of times, like smokers in the morning, you'll hear them, they're kind of coughing and doing a lot of that. That's because a lot of stuff is starting to move up because the mucociliary escalator is active again, starts moving it up, and then they want that first smoke to paralyze it because it's irritating to them. Okay. Submucosa, there's lymphatic nodules in there because it's an entry point to the body. Okay. And then cartilage, we mentioned hyaline. And then because it is outside of peritoneum, it is adventitia. All right. So the bronchi, they change names every time we split. So we have two primaries. Once we split, we go into the secondaries. Once we split again, we go into tertiary. So here's primary. There's the split. That is now secondary. There's a split again. That's tertiary. Take note, right lung, 3 lobes. Because it has 3 lobes, it creates the horizontal fissure. That's unique to the right lung. Left lung, 2 lobes. Has oblique fissure, and right lung also has an oblique fissure. I feel like I missed someone on 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Oh, I'm number 11. Huh? Thought I was missing someone for their participation. So here, primary, split, secondary, split, tertiary. Down here, we're going to talk about bronchioles, not bronchi. Okay, these are bronchi. Bronchioles, the difference is these are going to have smooth muscle. These are the ones that tighten up when you talk about like an asthma. That's what's tightening up. That's what, when we give a patient albuterol, we're getting it to release. Okay? And then at the very bottom, alveoli. Where's my pointer? That's where gas exchange happens. The rest of this is just for movement of air in and out. Okay? So primarily when you talk about lung damage, it's these guys, the alveoli. The rest, it's still functioning. It's just these are destroyed. Either we turn it to scar tissue, they collapse, something. Okay? That's what's being damaged. So bronchiole, that is that last little bit. The difference is it has smooth muscle around it. Autonomic controls it. So if I'm sympathetic, I'm running from the tiger, I want my airways opened up max. So they dilate. That allows max air movement. When I'm rest and digest, I don't need as much oxygen exchange because I'm not extracting it at the muscle at a high level. So they'll constrict down a bit. Okay. I had a question one time. Someone was like, really, why does it constrict at all? You get just slow breathing rate. And that's true. It doesn't make sense for it to constrict. And so, the thought is, I went searching into this and it makes sense. So my thought was the same, was that why do we start coughing violently sometimes? We're trying to push things out. Well, if you constrict it, you increase velocity, you increase the speed that it comes out at. So sometimes when there's an irritant in there, that's what, when I researched it, that's what they speculate why we have that ability to constrict. That's probably the primary reason, was to tighten down so that we can increase velocity and push things out that have made it in. That's the logic there. Unfortunately, it constricts too much. So when you talk about like an asthma, that's what's happening. A foreign substance has come in, we constrict, and air is now trapped in the alveolus. So this falls under COPD, a chronic obstructive pulmonary disease. They can't push the air out. They can pull in, but they can't squeeze it out. So what happens is we give them albuterol. Albuterol is a beta 2 agonist. Yeah, I could be having a brain fart. I'm pretty sure it's an agonist. Okay, works on the beta 2 receptor. Yeah, it's a beta 2 agonist. So what it does is it helps dilate those in an emergency situation, open them up. Okay. Random memory tool my wife had taught me. How do you know? So you guys at some point you're gonna have to learn beta 1, beta 2. And I thought this was one of those things like, why did no one ever point this out? Where these receptors are. So when you give certain drugs like beta blockers that we talked about with the heart, like propranolol or whatever all beta blocker you give, the problem there is it can work on different areas because there's those beta receptors. So some of those old school beta blockers, you would give it to a patient for their heart, and if they had asthma, it would start triggering asthma. It would close up the bronchioles. So we've created newer drugs where it targets just beta 1 or beta 2. And so what my wife taught me was you have one heart, two lungs, and that's how you remember where the beta 1 and beta 2 are. I was like, why didn't no one point that out? Right? So your heart has beta 1 receptors. So if you give a patient a beta 1 blocker, it only affects the heart. It doesn't affect the lungs because the beta 2 are there. I know, right? One of those things. So, yeah, we're a hybrid. You're good. Miss Miller popped in. Didn't know we were having class. All right, so here, you see this smooth muscle? That's the bronchiole. So when you guys think about the lungs, I want you to think grapes, okay? Think grapes. If you went and bought grapes and you pick up from the main stem, you have stems that are coming down, but you have grapes everywhere. The reason I'm saying this is that's exactly how the lungs are. The grapes themselves represent the alveoli. So when you look at a slide, you're going to see things at different levels. So when we slice the lung and we look at it, I have bronchiole right here. I have either ciliated columnar or cuboidal cells, ciliated cuboidal here, lining it. But then I have alveoli. They're just at different levels. Think grapes, okay? So when they slice this, they got a bronchiole. His alveoli would be below him, but simultaneously there's alveoli to his side. And that's what we're seeing, okay? So no cartilage here because we want to be able to constrict or dilate. The cartilage would inhibit that. All right, alveoli, that's where we do gas exchange. There's elastic fibers here. This is the other thing that gets destroyed when you smoke. Smoking upregulates two enzymes that affect the lungs and our skin, collagenase and elastase. That's why when you look at smokers, voice gets deeper because the vocal cords, it's attacking them. They're collagen based, so they get looser. And your skin has collagen and elastic fibers in it. That's why they get wrinkles. And then it does the same thing to your lungs. See, when we talk about breathing in requires ATP. The reason breathing in requires ATP, we have to operate what muscle? See if y'all are awake today. What muscle must we operate to breathe? What muscle makes you breathe? Did y'all run away already? I know y'all know this. Think lower. Diaphragm. 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 Okay. Do muscles push or pull? They pull. Muscles can only pull. So when we go to breathe in, we strengthen that muscle, we tighten that muscle, and it pulls down, and we pull air in. And these alveolar sacs expand. Muscles don't push. We just relax the diaphragm. Because we create a positive pressure in there, we push the air out of us. It's relying on the elasticity and the collagen in your alveoli to do that. So it bounces back. Okay? Emphysema is the destruction of that. So these guys, they call them, they're barrel chested. Why? The lungs start to hyperexpand because they don't want to recoil. So they're big old barrel chest. They are your blue, they call them like blue barrels, I think is the name, because they don't oxygenate well. So these are the ones that are on oxygen supply. They have COPD. Emphysema is just under COPD. Okay. We're just seeing a lot of COPD. So when I think of the alveoli and the capillaries, I think spaghetti and meatballs. My brain's weird like that. Okay. But I think spaghetti and meatballs. The meatball is the alveolus. The spaghetti is all the capillaries around it. So the capillaries are outside of the alveoli. They're not on the inside. Okay. So here they show a great example of it. This would be coming from pulmonary artery. And as we pass, CO2 leaches out. Why? It's a gradient. There must be less CO2 outside than what's inside. And it'll just automatically leach out. We don't have to do anything. And the oxygen will leach into the hemoglobin. Why? There's more oxygen outside than what's inside. That's the goal. And the hemoglobin attracts it on top of that. So we saturate the blood immediately. You'll see like typically patients are at 100%. 98 and up is considered like normal. Okay? We don't fret about anything else. So here they're showing all of these are alveoli. All of these. And that's a bronchial here. There's that smooth muscle. That would be cuboidal or columnar ciliated cells lining it. But that's all alveoli. That is what gets damaged. Between all these lines is where you find the capillaries. So between like this alveolus and this alveolus, capillaries are wedged between it. Right? When you look for a capillary in lab, you should see one red blood cell in it, and that's it. If you see a bunch, that's like an arterial. Capillary should fit one through it at a time. Okay. So as far as the cells go, when you talk about what makes up the alveoli, we have a couple things. Type 1 and type 2 septal cells or pneumocytes. Type 1, great for gas exchange. That's what we want. Type 2, not so much. But they produce surfactant. Surfactant is important for us. Surfactant is what helps your alveoli to stop from sticking to each other. So when the air gets pushed out of you and that alveoli walls touch, they'll pop away from each other. So the problem is like when babies are delivered normally, The stress of going through the birthing canal actually helps them produce surfactant. That's pretty much when they do it. Preemies, we can actually give the mom like a steroid shot and it'll cause the baby to produce it. Or, most of the time, just the whole birthing process in general, even if you're doing a C-section, is sufficient for them to produce surfactant. And they'll produce it pretty darn quick. Now, if they're too young, that's a different story. Like the lungs may not be developed fully yet. That's a different story. We also have phagocytes in there or macrophages to eat up debris that makes it into there. When you smoke or you have pneumonia of any type, you potentially damage that type 1 pneumocyte. It can flip to type 2. If you continue to assault it, the type 2 then will flip to scar tissue. Scar tissue doesn't diffuse oxygen at all. Okay? So that's what happens to when we have lung damage. If you ever had surgery and afterwards they make you do breathing exercises before they release you, the reason is some of the drugs they give you stop the production of saliva, surfactant. So it takes time for the system to come back on. So they're testing your breathing. They're doing sometimes like where they have you breathe against resistance to help pop things open. And that can help patients to be able to breathe better before they're released from surgery or after surgery. This is a great image. So here's our meatball. There's the alveolus. There's the spaghetti. It's between the alveoli. So whenever you guys draw these like in lab, never ever draw a capillary on the inside of an alveolus. It's always between alveoli. Okay. And when you look at it up close, this is the simple squamous cell of the alveolus. This is the simple squamous cell of the capillary. Cell membrane, basement membrane to fuse the two, cell membrane, cell membrane. So when you think about it, between you and outside world, your bloodstream and outside world is 5 layers. So if a bacteria cell could get in there to make it into your bloodstream, he's got to just squeeze through 5 layers. That's all it takes. And he could penetrate then. Okay? So that's why like pneumonia can be so dangerous. 1, it obstructs your ability to breathe, but 2, the patient can become septic very, very quickly. All right, lungs. So, like we mentioned, the lungs, right, has 3 lobes, has the horizontal fissure. Left has 2 lobes, and both have oblique fissure. Okay. Hilus is the entry point. We'll see this term again when we look at the kidneys. This is where things are coming in and out of the organ. So we have pulmonary artery coming in. We have the primary bronchi coming in. We have nerves coming in. We don't mention it here. And then we have exiting pulmonary vein. Pulmonary vein, remember, is carrying oxygenated blood back to left atrium. Pulmonary artery came from right ventricle. We're going to pass through arterioles, capillaries, venules, vein, back to heart. That's what we're doing. In that process, we are oxygenating it. Pleura. So visceral means stuck to the organ. So that's what's stuck to the lungs directly. Parietal is what's stuck to the outer wall. So that's what's stuck to the chest cavity. And diaphragm. There's our diaphragm. Pleural cavity is what's between the two. We find there's a serous fluid in there. And what we're going to see is these pleura and the pleural cavity, their integrity must be maintained. If you damage it, the lung will collapse. If you damage it, the patient can't pull the lung down with the diaphragm and with the chest wall, if they're breathing deep, to breathe in. So this would be visceral. That's lung. There is the parietal. That's like your outer wall, chest cavity. And that's pleural cavity. So when we breathe in, what we'll see is we pull this away. That creates a negative pressure in here. It's like a negative 2 or 3 millimeters of mercury. Nothing wild, but that's enough to suction the lungs along with it. It's the same concept as you ever had a drink on a coaster and you pick it up and the coaster comes along? It's that same exact concept. A bartender taught me long ago that if you sprinkle a little salt, it stops that. Life lessons. Life. I was an undergrad too once, okay? Don't hate. All right? We must maintain that suction. If we lose that suction, lung collapses. All right. Pulmonary ventilation, that's breathing in and out. That's inspiration, expiration. Okay? So we live in a environment that has pressure. We have atmospheric pressure. I believe it's like 760 millimeters of mercury. I don't know how I remember that. Or 1 ATM. Okay? So when you breathe in and you pull your lungs down and out, you expand them, you create negative pressure internally. So what does the air do? Just flows right in. When you breathe out, because you are relaxing the muscles and because of that elastic fiber, that collagen, the alveoli, everything compresses back down. When it does that, you create positive pressure inside of you that is greater than the outside world. So what does the air do? Just flows out. Okay? Conducting zone, that is nose to bronchioles. No air exchange. That's where we're talking about. We're just moving that air back and forth. We're conducting it. We're a conductor, like on a train. We're just moving stuff back and forth. Respiratory zone, alveolus. That's the only place we talk about. That's where we're exchanging CO2 and O2, hydrogen ion. Okay. So diaphragm, to breathe in, it has to move. It has to move down. It requires ATP. We're moving a muscle, so it requires ATP. The phrenic nerve supplies it. So I remember the C3, 4, 5 keep the diaphragm alive. It's an old memory tool. C3, 4, 5 keep the diaphragm alive. There is a phrenic nerve to each side. So sometimes you'll see patients, they'll damage one of them, one side or one of C3, 4, 5, and they'll damage phrenic nerve and only like half their diaphragm works. They can only pull on one side. It's pretty wild. Right? You'll see it like they'll do an MRI and stuff, and you can just see it's like lopsided. So they lose functionality of lungs because of that. All right. External intercostal muscles. So this is moving the chest cavity out. This is expanding the rib cage. When you're sitting there, this book kind of describes that we're doing it on every breath. A little bit, yeah, a little bit we are, but it's also going to say we're going to do the same when we're breathing out. And that's not true. Muscles relax, they just kind of go back to where they're at. We're going to compress the lungs. But breathing in, I can go with it. We're going to move the diaphragm down, we're going to move the chest out, we're going to pull parietal pleura. That is going to create negative pressure inside the pleural cavity, that suction of like the cup sticking to the coaster, and we're going to pull the visceral pleura with us. By doing so, we're pulling the lungs open wider. By doing so, we're creating less pressure inside, air flows in. Okay? So, inspiration, we're creating, here. The pleural cavity, it's always a negative pressure. That space, it's always at like a -1 at rest. There's some conflicting stuff here. Because when you breathe out, it actually does go positive a little bit. It would go to 0 or +1. And that's to let the lungs push the air out. But for inspiration, it is truly always at a negative. When we're pulling air in, it's at a negative. We're pulling pleura, parietal pleura. We are creating negative. We're pulling visceral pleura. By doing so, we expand the lungs. By doing so, there's less pressure inside of me. So what happens? Air rushes in. That atmospheric pressure just pushes it in. So inspiration, active process. What does that mean? What do you need? Do you need your brain? You need your lungs. What else? It's active. You're actively moving a muscle. ATP. You need ATP. So it's interesting, that brings up a good point. Subconsciously, you do control your breathing, right? I don't have to think about it in my sleep. I'm not going to sleep too well at that point. The brain takes over. The brain controls it. Hold your breath as long as you want. You're going to pass out and start breathing. You won't die, right? You're not going to die. The brain controls it. So it requires ATP. We have to move a muscle. We're pulling. We're pulling the external intercostal muscles to open up the rib cage. Because we're doing that, parietal pleura moves. Because of that, pleural cavity creates negative pressure. Because of that, we pull visceral pleura and we pull air in. The accessory muscles, this is like when you're working out. You're taking big old deep breaths, stuff like that. So we have pectoralis minor, scalenes, and sternocleidomastoid. Okay? So intrapulmonary pressure, that's inside the lungs, decreases when we do this. Atmospheric pressure is greater, air moves in. It's the same way an engine works. This image is in your book. You guys can go through it. It's what we talked about. And it's just showing how everything expands and diaphragm would move down. Expiration. Expiration should be considered passive. This is where I have the discrepancy with the book. Breathing out is passive. Why? Because collagenase and elastase of the lungs, and because relaxing of muscles. If I relax those external intercostal muscles, I relax my diaphragm, I start to squeeze. When I start to squeeze, I'm pushing parietal pleura in. I'm pushing on pleural cavity. By doing so, I'm starting to create positive pressure. By doing so, now that recoil of lungs is active and it's pulling itself in, and visceral pleura moves, lungs move. We create more pressure intrapulmonary or within the lungs, and it's greater than the outside world, and air comes out. Okay? So here they want to bring in the internal intercostal muscles constrict to pull the lungs closed, and that's where they're saying ATP is required. I mean, when someone dies, they breathe out, right? Their last breath, they breathe it out. They're not using ATP to do that. And that's just relaxation of body, okay? So really, expiration should be considered passive. So it's the same process. That's what we just went through, okay? Just reverse it. So expiration, they say mostly passive. It's passive. We relax diaphragm. We relax external intercostal muscles. This is where the other point they get into, that we contract the abdominal muscles to help push on the diaphragm. We push intestines, stomach in. We push up on diaphragm. Now, when you look at like people that run, yeah, they do that. Runners, you'll see they'll control their abdomen even. They'll let it expand out so the diaphragm can move lower. They can take in deeper breath, and then when they're pushing out, they contract, they push, and push everything out. They're taking bigger breaths to maximize stamina over time. Okay? So same thing with this image. It's in your book. You can run through it. Okay? All right. So what happens if you rupture these pleuras? Either way, when you do that, you collapse the lung. So the pneumothorax is air in the thorax. And you can do it from either side. The lung can rupture or the ribs can. So you see here, air has come in. You can see the broken ribs. They've had trauma here. There's puncture from the outside. And usually what happens here, they create a flap internally. Like as whatever punctured them goes in, it creates a flap on the inside. So every time they breathe in, they pull down on that diaphragm, the flap opens and air goes into their chest. And then when they breathe out, it closes. And so every time they do that, they create more pressure on the one side and collapse the lung. Oh, we had a question. So for people that have sleep apnea, does the brain stop breathing and starts again for a little later, or do they have to signal that the lungs are no longer moving? It starts again, just as you mentioned, the brain takes over. So in that situation, there's an obstruction typically. There's like too much on their chest, something in the airway, and so it'll kind of block and they'll intermittently stop, and then the brain kicks in and goes, you really need to take a deep breath, and usually you hear them gasp for air at night. That's typically what you see. And we're seeing a lot of sleep apnea lately. What else? Another thing you see with sleep apnea, polycythemia, because they're not oxygenating like they should. So they got a little more viscous blood. Uh, they It was kind of wild. They said I think the biggest group or job that had sleep apnea was truck drivers, because they don't do anything but sit all day, eat, and drive. So they all gain weight. So one of the big things they talk about with sleep apnea is chest size. So as we get bigger, that compression it's harder to work against. Neck size, those are big causations for sleep apnea. But then like things like tonsils can affect it. So there's quite a few things. But yeah, the brain will kick in and you'll hear them do that in the middle of the night. So what do? We give them CPAP. CPAP is positive pressure. So they wear a mask, it has to seal. And what it does is it provides a little positive pressure to help push air in, and then they breathe out normally. Um, Not a fun thing to wear, but they get used to it. Okay. The other thing is like when they're bigger chested, sleeping on their back will trigger it. So something people will do to help with sleep apnea, they literally take a shirt and they sew tennis balls onto the back of it. And so when they sleep, they'll put that shirt on, and if they roll onto their back, it's uncomfortable and it makes them roll onto their side, and that can help prevent sleep apnea too. It's like an old school trick. But yeah. All right, so back to pneumothorax. You see the diaphragm down here? That's because all that positive air in there. Look at how much the heart has shifted over. This is translucent because the lung is all squished down. It's collapsed. So what do? We stick a tube in here and we relieve that pressure. And the lung will reinflate eventually. Here, this is a bleb. So people can have spontaneous blebs. They'll rupture alveoli, and it's the same thing. Lung will collapse. You typically see this in Ashkenazi Jews. There is like due to like they don't have children outside of their culture, and so the genetics have overlapped a lot. So you see a lot of these genetic diseases in them, but they tend to have a lot of spontaneous pneumothorax. One of my middle sister's friends, I think by his age of like 24 or something, he was early 20s, he had already had it 3 times. And I have a student recently that told me he's also Ashkenazi, and he told me he's had it a couple times. He had spontaneous pneumothorax. So typically they just get admitted to the hospital. We just relieve the pressure. It'll seal back up and they'll be fine. But this case, this is trauma probably because of the broken ribs, something punctured. And one of the worst thing you can do is like if someone gets stabbed, you don't pull the knife out. It's actually better to leave it in because the second you pull it out, now it's a hole, there's that flap, and their lungs start to collapse, and eventually it'll collapse both. So that's just what happens there. Okay. So atelectasis really, it's really collapse of alveoli is really what it means. Here they're trying to say it's like pressure on the lungs causing them to collapse. Really, if you don't have surfactant, that's atelectasis too. The alveoli stick to themselves. It's an internal collapse. All right. Man, we are blowing through this. I'm going to call it here. Let's stop here. This is a good stopping point. Let you guys get through that, and then we'll carry on with elasticity, compliance, all that good stuff. This image is kind of wrong, okay? So don't go with this yet. Ignore this right now till I talk about it. All right? Any questions? If not, go study. Lab people, go to open lab. Start. Get ahead. Get ahead. Makes life easier, especially when you get towards finals. Get ahead. All right. I will see y'all Monday.